I'm going to share my screen now, and we'll talk a little bit about some of the data that's come out recently regarding long COVID and maybe the spectrum of long COVID being a bit more varied and widespread than we have previously believed. So there's been really over the course of the pandemic information coming out in bits and pieces that indicate the long-term neurodegenerative and neuropathological effects of SARS-CoV-2 infection are probably underappreciated, and this should provide, I think, additional pause for folks who are in the COVID is mild, Omicron is mild camp, that those memes are really misrepresentations of the truth for a variety of reasons. But also, we're learning more and more that just because you don't end up in a coffin or in a hospital doesn't necessarily mean that you are not going to have long-term adverse consequences from a COVID-19 case, even if it may seem mild. I'll bring you back. This was last summer where we talked about this study that looked at autopsies of people who died of acute COVID and showed that there were signs of significant inflammation in the brains of folks who died. And we just discussed the fact that CNS component of acute COVID-19 is probably under-recognized and underappreciated. Now we're getting more data that's come out recently about some of the long-term consequences of SARS-CoV-2 infection. So this paper was just published, and it is on a preprint server, so it has not been published in the journal yet, so still hasn't gone through complete review, but these folks from the NIH, Dan Chertow is a pretty well-known critical care physician from the NIH Clinical Center, and these are all pretty respected folks. So this is not the B team that's come up with this study. They did a study of 44 patients you see here who passed away after a COVID-19 infection. Importantly, these were not people who passed away from COVID-19 necessarily. In fact, the majority passed away from something else and then were autopsied because they'd had a relatively recent infection with COVID-19, at least within the past 9 months, I think was as far as they went out. But the important findings in this study are in bold there. They detected SARS-CoV-2 virus in multiple sites, including the brain, for many months after initial infection. So you can see that they were able to detect virus 7.5 months later in the brain and in other organ tissues. And so if you look here, the central nervous system is the last set of boxes, and the number down there with the other arrow is how many days out after infection. And you can see quite a few of these autopsies were able to detect virus. So you can see a completely white square is actually no virus at all. And you can see all of these patients have at least one site in the central nervous system where they were able to find virus RNA, which again means that there's active replicating virus there somewhere. You can also see that on histopathological examination with special stains, you can find evidence of the virus in a number of anatomical sites within the central nervous system. This now is starting to translate into more evidence about the actual functional impact of SARS-CoV-2 infection. And this may be the presence of virus, it may be the immune response to virus, probably potentially a combination of both. But this study was just printed in bioRxiv and shows that features of long COVID neurocognitive impairment and damage after SARS-CoV-2 infection mimics very closely what's colloquially known as chemo brain, right? So that's this syndrome of cancer therapy related cognitive impairment, which is a widely recognized sequela of chemotherapy in patients undergoing treatment for cancer. And what they found is that the nature of neuroinflammation, so inflammatory response within the brain, particularly in microglial cells. So those are essentially the immune police of the brain. They're essentially macrophages, tissue-dwelling macrophages that live in the brain that kind of orchestrate immune response against invaders, et cetera, et cetera. You see significant upregulation of microglial reactivity. That means inflammation in the brain, and dysregulation of oligodendrocytes in white matter, that are the cells that essentially make the nice protective myelin sheaths that surround nerve axons that are the transmission lines for the brain. And that's what you see in chemo brain. That's also what researchers are finding in brains of people who have survived COVID-19. So they developed a mouse model of SARS-CoV-2 infection where they were able to show in the white matter there's significant evidence of inflammation, and that lasts 7 weeks. So you can see at 7 days there isn't a huge difference in the micrographs that they have here, but at 7 weeks you can see that starry shot on the right in box F there is the inflammatory reaction, so microglial cell inflammatory reaction. In the white matter, that's significantly different from that control on the left, whereas in the gray matter, that distinction and difference is not nearly as profound. You can also see in the hippocampus here, which is an important part of your brain for memory and emotion and other basic reactions, is significantly impacted 7 weeks after infection with reduced neurogenesis, so generation of new cells and neural connections, which is obviously important for brain remodeling and healing. And you can see that's microglial cells, sorry, that should have been hippocampus, or neurogenesis in the hippocampus. What they also found is this data that they found in their mouse models is paralleled in some of the data that they have from human specimens. So this CCL11 is a chemokine indicator of microglial reaction and inflammation in the brain. And you can see they saw elevated levels in their COVID-infected mice. They also see elevated levels in human serum from people who have long COVID syndrome with the presence of what's been, kind of termed brain fog, compared to people post-COVID who don't have brain fog. You can also see that their micrograph pictures show this activation in the white matter, similar to what we saw in the mice, with a significant difference between non-COVID patients. And that is, statistically significant in the white matter, but not in the gray matter. So that appears to be that inflammation and areas where white matter is predominant seems to be a feature that again simulates what we see in chemo brain. So again, in this study, they note striking similarities between the post-cancer therapy neurocognitive inflammatory syndromes and SARS-CoV-2. And this may be one of the explanations of this long-term, long COVID brain fog and other neurocognitive deficits we see in COVID patients. This is now being backed up by other studies that show functionally these things have consequences. So this was a study that was published just recently in this journal, Brain Communications, that showed essentially significant deficits in people who went through various tests of neurocognitive performance. So you can see that, and the more I read this study, the more interesting it became, to be honest. So this was a cohort of 64 COVID patients and 91 controls. Interestingly, the vast majority of the COVID patients, as you can see, had mild disease. Only 3 were admitted to the hospital. Only 7 had symptoms significant enough to impact daily life, and only 2 reported having long COVID symptoms. So the vast majority of these folks had mild symptoms and didn't think that they had any significant impact from their COVID disease. The other thing to note is that this was a very young population. You can see that the median age or mean age for these folks is under 30 for the COVID patients and the controls. And so they went through this series, this bank of tests. You can see testing things like memory and reaction time and those types of things. There's the young age that I noted, which is, I think, really important to think about. And what they found in this study is significant degeneration of their performance on these tests. in COVID patients compared to control patients. You can see their accuracy in performing some of these neurocognitive tests was significantly lower, as was their fatigue rating. And this effect lasted for over a year. It was, as you can see, about 420 days before that, what's kind of the regression mean or the average performance of these folks actually got back to what you would consider baseline, or no decrement. That's a pretty significant finding. The other thing to note is essentially when you compared the function of these patients with COVID, again, 28, 29-year-olds on average, to controls that are age matched, they performed significantly less well on these tests, and essentially were the equivalent of people over the age of 50, essentially called elderly in this study, which is really depressing, but nevertheless. Essentially these late 20-year-olds were performing on these neurocognitive tests like they were 60 or 65 years old. That's a pretty huge difference. And if you look again, the time from onset until they actually regain kind of normal levels of function is again almost a year, right? That's about 8 months. So huge differences in their performance that are very long lasting. That arrow there is showing that they're essentially performing statistically about the same as the elderly control group. Finally, this last study comes from Canada. It was a study of functional ability of patients after COVID compared to controls who did not have a diagnosis of COVID. This is a large study, as you can see here. It actually is a cohort study that they have that's been ongoing, that's over 50,000 people, and you can see they were able to follow about 8,000 COVID patients who were under the age of 65 and over 16,000 COVID patients who were greater than the age of 65 to do both baseline testing and exit testing after their COVID diagnosis. And what they found is they had significant decreases in their ability to engage in housework activity, significant decline in their ability to engage in physical activity in general. You can see those differences are pretty severe, including significant decrease in their ability to move around the house. So if you were recovering from COVID, you had anywhere from 1.5 to 2 times or 2.5 times the likelihood of having one of these disabilities or deficits compared to non-COVID. When they looked at specific activities, this was true for difficulty standing up after sitting in a chair, difficulty walking up and down a flight of stairs. The only difference, at least with probable confirmed COVID, that they didn't see was in walking 2 to 3 blocks. But you can see if you include suspected COVID cases, so those that had clinical syndrome compatible but never got diagnosed, you still see significant differences. So this seems to indicate that many, many months after COVID diagnosis, people still had true functional deficits. And this is, again, an older population of most are over 65, but again, about a third of them were under the age of 65, had these significant findings. Some good news, so maybe the silver lining that we can talk about here is this study that was just recently published out of Israel that showed a complete vaccination series, which at that time was still considered 2 doses of vaccine, provided excellent protection against development of long COVID symptoms like fatigue, headache, weakness, and persistent muscle pain, which were relatively common features of long COVID. So if you were vaccinated with 2 doses, you can see there that you cut your chances of having one of those long COVID symptoms by more than half. So it seems to provide additional evidence, again, that vaccination not only protects against infection, severe disease, and ending up in the hospital, or obviously ending up dead. Vaccination also seems to provide protection against long COVID if you are infected with COVID-19. That's all I have, Shelley. Thanks.